only 9 to 19% of those who have thyroid autoimmunity ever become hypothyroid. So it's important to disclose that because it's portrayed as, oh my God, you have thyroid autoimmunity, like it's this ticking time bomb that you can do nothing about. But actually, there is a minimal risk of progression. It is the most common cause, but of those who have the autoimmunity, only 9 to 19%, at least according to the best prospective study from Tehran that looked at this, actually convert to full-blown hypothyroid. So I just want to plant that one little caution flag. So if you do have Hashimoto's, don't freak out. It's not like an 80 or 90% probability. It's actually much lower. But in those who do have thyroid autoimmunity, there's also an overlap to potentially having autoimmunity against the cells of the stomach that produce hydrochloric acid. It's about a 20 to 30% of those who are full-blown hypothyroid who may also have this diminished stomach acid secretion, and that opens the door for SIBO because you need to have a highly acidic content from the stomach coming into the small intestine to make it unfavorable for bacteria to overgrow.
Welcome back to another show. You're in for a real treat today. We cover many aspects of gut health that you may not have heard before, like the connections between hypothyroidism, poor stomach acid, and imbalanced composition in the small intestine and also colon, known as small intestinal bacterial overgrowth. We talk about why stomach acid and why digestion is so important for the composition of your intestinal bacteria, and when those bacteria become altered, what that means from your immune system standpoint in terms of autoimmunity, allergies, inflammation. We talk about helminth therapy, parasites, fecal microbiota transplantation, also known as FMT. Like we explore bile acids, we get into a lot of stuff. It's a great show. I would encourage you to check out the show notes below so you can really fast forward to the timestamps that are of particular interest to you. Now, today's show is brought to you by our very own Myoscience Nutrition. One of the aspects about supporting gut health and diversity and stability of your microbiome that we don't talk about in the show, but there's a lot of scientific evidence to support this, is vitamin D sufficiency. So when you ingest vitamin D, around 4,000 to 6,000 units, some of the studies have shown, guess what? You improve the composition and therefore the stability of your intestinal microbiome, which is so important right now when it comes to cold and flu season, and especially the C word that's circulating in our communities. Not only is vitamin D insufficiency a risk factor for severe outcomes for the C word, but it's actually really important for just overall immune health and also gut health. Believe it or not, several human clinical studies have shown that vitamin D repletion actually improves the composition of the microbiome. So I want you to have a diverse and stable microbiome ecosystem. So what we have over at Myoscience, and one of the products that I formulated, was a combination formulation that has vitamin D and vitamin K2 in the MK7 form. Now it's important to take these two nutrients together because they're synergistic and they help to mobilize and most efficiently help you metabolize calcium in your body. So you can support your body's gut health and your vitamin D levels by going over to our website, myoscience.com. That's MYOXCIENCE.com. I'll put links below to the essential fatty nutrients combination formula of vitamin D and vitamin K2 together, and a special coupon code just for you in the links below. That coupon is podcast at checkout over on our website. So I really hope you enjoy this show, and I'll put links to that research about vitamin D and the gut health and diversity and so forth below, and the show notes and links to Dr. Michael Ruscio's website. So I appreciate you tuning in, and let's cut back to it and talk all about SIBO, autoimmunity, and much more. Here we go. Well, Dr. Ruscio, so great to have you on here. And we get a lot of questions about small intestinal bacterial overgrowth. And I know this is a conversation, a topic that has been a focal point in your clinical practice for a very long time. I've known of your work since, I want to say 2014, 2013, in that range. I think we launched our podcast around the same time in 2014. So it's great to be with you. Great to have you on. And let's talk like big picture. How prevalent is SIBO, if we can kind of estimate? Because I think a lot of people, I know a lot, and you know, a lot of people have bloating. A lot of people feel lethargic after a meal. They eat a small amount of whatever and they feel bloated. And so I feel like this condition is a lot more prevalent than a lot of people recognize.
Yeah, and the estimates do vary quite a bit. Some studies have found as low as 4% overlap with IBS. Some have found up to 84%. Some more recent meta-analyses have given us a better feel on that. And I don't know what the exact percentage of the most up-to-date meta-analyses are off the top of my head. I believe they fall into maybe the 40 to 50% range. So, that can be sizable. That's 40 to 50% of IBS. IBS impacts about 20% of the population. To juxtapose that with hypothyroidism, that impacts only about 2 to 3% of the population. So there's a notable increased prevalence in digestive disorders as compared to thyroid. And that's not to diminish the thyroid disorders, although kind of in the theme of the big picture, one of the things that is pretty alarming at the clinic is how many patients have been forced into a thyroid diagnosis when it's actually the gut at the root of their problems. And this is compounded by functional markers that are proclaimed to be diagnostic of hypothyroidism, even though they're well within the normative ranges for LabCorp and Quest. So what I would argue, somewhat fictitious ranges that maldiagnose someone as hypothyroid, and then a pursuit of various medications. It's sad that we'll see cases that have been on various thyroid hormone medications for a year to a year and a half, all the while their underlying IBS, SIBO, inflammatory issues in the gut have been ignored. And this is where their fatigue, constipation, and brain fog are coming from. And we've published, and when I say we, it's not just me, it's other doctors who read my clinical newsletter or are in my clinical practice who are finding the same thing, and just simply applying, I guess you would say, an algorithm of starting with the gut, not ignoring thyroid, but looking at someone in front of you and not proclaiming that a confection of certain symptoms plus this questionable lab interpretation guarantees hypothyroid. So putting that on the back burner, starting with the gut, and it's amazing how many of those symptoms will ameliorate once you've addressed the gut. So sorry to be a little bit tangential, but I think that is one potentially really valuable big picture insight to throw people. It seems on the internet, the thyroid being blamed for the problems of a litany of symptoms is much more common than the gut. But in actuality, the stats show us that GI disorders, gut disorders, are orders of magnitude more common than thyroid disorders.
I would love to drill down on the mechanisms and talking about, specifically how imbalances in the gut, the microbiome, digestion as a whole affects the thyroid. But first, I want to just echo something that you said. Is I hear this more than anything, and I've been publishing content online since 2010, and it's all about the thyroid. I have hypothyroidism, but this, or is fasting okay if I have hypothyroidism? Well, I have keto, so we hear this so much, and I get a lot of calls from friends and then clients that I do consultations with who are being treated for their thyroid. Usually was just Synthroid and no other T3, for example, but their labs are normal, but they still feel like crap. So it adds a little bit of, more anecdotal evidence to kind of what you're saying here. So how is it, maybe we can talk about SIBO or all gastrointestinal disorders, but when we have a imbalanced gut bacteria or digestion, what does that do to the thyroid, or does it just mimic the classical symptoms that are characteristic of hypothyroidism?
Yeah. Great question. It's much more the latter of those two scenarios. And I think it's really important for people to understand that it's one thing for me to make a proclamation that it's the gut causing these symptoms, but we actually have the evidence where probiotics have been shown to alleviate depression. A low FODMAP diet has been shown to alleviate fatigue. So we have the outcome data that goes a step beyond theory, and unfortunately that's a lot of what you see when someone's trying to defend it's a certain ratio of T4 to T3 or TSH should be below 2.5. A lot of that is actually just inferential. And there's not any actual or very, very sparse outcome data to support those contentions. So yes, it's much more the latter, where if we think about the symptoms are kind of the superficial layer, and a good clinician should be able to drill down into, well, what causative layer issue is leading to those symptoms? Because fatigue and, fatigue is just one, fatigue and mood disruptions, mood lability, both of those associate, or those both associate either to IBS, which has been documented, or to thyroid. But then if we come back to the prevalence data, if these GI disorders are 20% prevalence as compared to maybe 3% prevalence, then it would make much more sense with just knowing that we should start with a good gut evaluation and then reevaluate. So it can work to the first part of your question, the former of those two. So this is something that still falls into the algorithm of start with the gut, because some patients who are on, let's say, LT4 as Synthroid or levothyroxine, they will actually be malabsorbing that medication. And there are some models either using ulcer or H. pylori that have looked at patients who have this kind of up and down TSH and up and down thyroid hormone dose. And when correcting the underlying gastrointestinal issue, they see a stabilization of their TSH and actually, in many cases, a reduced need for the dose, because remember, all of the thyroid hormone is absorbed in the small intestine. So if there's this active inflammatory issue, whether it be SIBO or perhaps non-celiac gluten sensitivity or ulcerations, then that can thwart the absorption. There is also some evidence, and sorry to be a little bit long-winded here, but trying to pull all these together. There is also some evidence showing that autoimmunity in those who have SIBO is a little bit worse for thyroid autoimmunity. But I should be very careful to disclose that the difference between the non-SIBO and the SIBO group, it's fairly marginal. So it's not to say there was a huge disparity in the levels of autoimmunity, but there was a slight disparity. And the reason why I just disclosed that is because even though that may be convenient for me as a gut-centric provider, I don't want to irresponsibly cite that footnote and give people who have SIBO this fear of autoimmunity. So there's a subtle impact, but nothing, at least to date, has been robustly documented that if you have SIBO, you're at a much higher risk for thyroid autoimmunity. Certainly wouldn't hurt to try to fix the gut condition, but I don't want people to kind of fall over the deep edge regarding worry.
Yeah, that's an excellent point. One thing that I wanted to kind of gather from you, and I think it's fairly well known amongst practitioners, but the peripheral conversion of T4 that the thyroid makes into active T3, a lot of that is in the systemic periphery. I believe the liver plays a big role here, probably the gut. Do you know rough percentages of this peripheral conversion to the active thyroid hormone and where those occur?
Great question. The liver is responsible for a sizable percentage, as is the gut. I don't know I used to know the exact numbers off the top of my head, but the exact percentages, they are not, the periphery is more than the liver, but the liver and the gut do definitely play a role. Yeah, absolutely.
So if you have inflammation or, inflammatory cytokines or bacteria, things like that coming through, burdening the liver, then it seems a reason that you could have reduced conversion peripherally or within the GI hepatic system of thyroid hormone.
Correct. Yeah. And so, the conversion issue is a very interesting piece. It's something that we've really been looking into and trying to have a intellectually honest review of the literature here. And so to throw out some stats to kind of help people understand how, unfortunately, kind of inverted the current functional medicine care paradigm is, about 10% of patients are documented not to adequately respond to T4 alone. So the narrative that you get on the internet is, well, everyone should be on T4 plus T3 because it's so much better for you. But, again, when you look at the outcome studies, there is a percentage, and that should be acknowledged, and that should be integrated into our care model. Yes, because we want to be able to help those patients, but it's also a travesty to force upon them combination therapy when the causative issue, and what I'm claiming here in many of those cases, is the gut is overlooked. And so this is just, it's not an issue of right or wrong, but how do we organize these things in an algorithm so that we proceed or towards the most likely culprit, and then through the process of elimination, we work downward. So about 10% of people aren't adequate responders, and that does overlap with some of the prevalence of the genetic polymorphisms that may make someone a non-robust responder. But, and this hasn't been published, but I suspect that of that 10%, there are some, to your point, who are inflamed, too low calorie, too low carb, and those things are thwarting their conversion. And so there's not really a need to give them a different medication, but rather go to a foundational level deeper to lifestyle and dietary issues.
That's a really good point. I'm glad you mentioned that, because I think there is a knee-jerk reaction, even in the functional medicine space,
okay, you have, your TSH is off, low T3, so we're going to give you a combination. But like you said, I mean, if 90% of people do seemingly respond to some T4, then maybe we don't do this uniform approach for every single person. You got to kind of figure out. But and I think one aspect that would help with that is figuring out really what's going on in the gut. So we've been mentioning SIBO. Maybe we could kind of define that, and then what really is it? Or if I'm sure it's multifactorial, but what is it in the 21st century life that is predisposing individual to having higher levels of bacteria where they probably shouldn't be?
Sure. Yeah, great question. SIBO stands for small intestinal bacterial overgrowth, and this is where there's too much or not the right type of bacteria in the small intestine. This is a quick maybe step back. The reason why the small intestine is so important is this is where the largest density of immune cells in the entire body resides. And so this is where the inflammation and kind of immune component ties in. It's also where 90% of caloric absorption occurs. And it's a primary spot for nutrient absorption. And because it's so selectively permeable for nutrients, it's also the most susceptible to leaky gut. So it really, if we were to pick one section of the gut that's the most important, it would probably be the SI, the small intestine. Not to say it's the only one, but vitally important for all those reasons. And in SIBO, or small intestinal bacterial overgrowth, we used to think it was just from the end of the line or the colon, those bacteria refluxing upward into the small intestine. However, recent research is challenging that. Richard McCallum, who's been on my podcast, he's a gastroenterologist who did a fairly eloquent study looking at jejunal. So they would stick a tube down the throat and take a sample from the jejunum and compare that with those who were SIBO breath test positive. And so when they actually can collect the bacteria, they can culture it out and tell you what specific bacteria are in there. The SIBO breath test just tells you, is there too much gas? So you can infer there's too much bacteria because the bacteria produce the gas, so too much gas, too much bacteria, but you can't tell what type because you're only really measuring two different gases. What McCallum found was that most of the overgrowth or the bacteria that shouldn't be there were from the upper GI. So there can also be this kind of top-down phenomenon, and this may explain actually why those with hypothyroid are actually more at risk for SIBO. So the association goes in both directions. And this may be because thyroid or hypothyroidism is predominantly an autoimmune condition. And just as a quick aside, I hope I'm not getting too kind of convoluted here, but there's just so much to unpack. Only 9 to 19% of those who have thyroid autoimmunity ever become hypothyroid. So it's important to disclose that because it's portrayed as, oh my God, you have thyroid autoimmunity, like it's this ticking time bomb that you can do nothing about. But actually, there's a minimal risk of progression. It is the most common cause, but of those who have the autoimmunity, only 9 to 19%, at least according to the best prospective study from Tehran that looked at this, actually convert to full-blown hypothyroid. So I just want to plant that one little caution flag. Mm-hmm. So if you do have Hashimoto's, don't freak out. It's not like an 80 or 90% probability. It's actually much lower. But in those who do have thyroid autoimmunity, there's also an overlap to potentially having autoimmunity against the cells of the stomach that produce hydrochloric acid. And it's about a 20 to 30% of those who are full-blown hypothyroid who may also have this diminished stomach acid secretion, and that opens the door for SIBO because you need to have a highly acidic content from the stomach coming into the small intestine to make it unfavorable for bacteria to overgrow. So that may be how some of these things kind of associate. So that's the definition of SIBO. It may be from the top down, and those with hypothyroidism perhaps are more at risk for this top down phenomena, and that can be remedied by hydrochloric acid as defined on a case-by-case basis. I wouldn't say everyone go out and use hydrochloric acid, but that's something that can be defined person to person. If you're over 65 and if you have a history of anemia, that also increases your probability. So if you have those factors in your medical history combined with having Hashimoto's hypothyroidism, then you may have up to a 50% chance of doing well with HCl supplementation. Try it, see if you feel better. If you do, continue. If you don't worry about it. Don't, aimlessly just take the pills unless you're noticing a clinical benefit. And then some of the SIBO may be from the contents in the large intestine where there's more bacteria kind of squirting upward and seeding into the small intestine.
Oh my gosh, that's super fascinating. I had not heard about, and maybe I'm getting the vernacular wrong, but cross-reactive molecular mimicry, is that kind of the phenomenon that would describe the same antibodies that are produced against the thyroid that would attack the stomach cells? So it's...
Yeah, good question. It may be. The antibodies that we see in the stomach are called antiparietal cell antibodies. And there may be some type of cross-reactivity between the thyroid, specifically probably the TPO antibodies, thyroid peroxidase, and the parietal cells. I don't know if that's been demonstrated, but to your point, molecular mimicry and cross-mimicry is one of the mechanisms that kind of seems to pervade many of these autoimmune conditions. So it's certainly possible, yeah.
That's amazing that that there be that shared connection, because digestion. When I first got into the functional medicine space in 2006, all the old school practitioners, this was before kind of SIBO was recognized, at least in the peer-reviewed medical literature and things like that, would always focus on kind of the basics and stomach acid, making sure you're digesting from north to south. And it's pretty cool now that we have a lot of the data, to support kind of what people quacks back then were promoting. So it's pretty interesting. And Gerard Mullen, who I think you probably had on your podcast as well, he's over at Johns Hopkins. He used to talk about kind of leaky sphincters. So, because people are in a sympathetic overdrive tone, they're not sending a lot of central nervous system, nerve intervention to the GI tract. So kind of reflux and leaky sphincters. What do you think about that concept?
Yeah, great question. I was initially actually quite skeptical of the leaky sphincter hypothesis, and there was some published evidence showing that those who have had their ileocecal valve surgically removed did not have an increased prevalence of SIBO. But there was further data, kind of these more, I believe it was either systematic review or meta-analysis. So for the audience, those are just papers that review all the available evidence. So it's a great summary where there was an association to IC or ileocecal valve dysfunction and SIBO. But I think what ends up happening there is the sphincter dysfunction is just a deeper symptom of either inflammation or dysbiosis. And so it's all about looking at these data points and making sure that you don't get caught up in kind of a bell and whistle and saying, well, what are the specific therapies I can now do for the ileocecal valve? And this is maybe more of like a conventional medical paradigm, which definitely has a time and a place. But I think in functional medicine, we're trying to think about, well, do we need specific IC therapies, or is there an observation that, let's say, the interstitial cells of Cajal, which regulate motility, those can regenerate, but that regeneration is thwarted by inflammation. And some very contemporary information is suggesting also by dysbiosis. So then if we work to restore the healthiest gut microflora ecology and reduce inflammation, that should then allow those cells to regenerate. And so you're going kind of a causal level deeper by focusing on the inflammation and the dysbiosis. And that inflammation think about if your knee was always inflamed, would you be able to heal your knee? So that's kind of the way I look at this through the lens of motility.
Oh, that's amazing. So just so I heard you correctly, so if you have maybe you're constantly eating processed food, liquid, sugar, fat together, creating dysbiosis, that's going to create inflammation. That's going to slow down literally the motility of the gut. And then we know that sluggish motility can cause more calorie extraction. So you can see how it's like a double whammy for not only inflammation, autoimmunity, and all that, but also potentially weight gain. So yet another reason not to eat fast food and things like that, right?
And to your point, which is an excellent one, there have been studies that have found that those with small intestinal bacterial overgrowth appear to, on average, have a heavier weight. There are also some people who can have very marked malabsorption and become underweight. But there seems to be a trend line also where it associates to a higher body weight. And in part, that could be through this calorie extraction or harvesting theory, where the slower the food goes, the more you can pull calories out of it, to your point.
Oh man, that's super crazy. Okay, a couple of things, because I love where this conversation is going, but let's kind of finish up off on the stomach acid. Sure. There used to be technology, I'm sure it's still available, the Heidelberg technology, where you swallow the capsule. Do you use that clinically?
I don't. It's something I've thought about for the cost of the test, for how difficult it was to find a center near me or near a patient who may be, doing telehealth with the clinic. It just seemed kind of challenging. Also, I've found that if you look at those history factors of age, autoimmunity, and prior anemias, plus, so that kind of gives you the, okay, if those things are there, then on our list of potentials would be a trial of hydrochloric acid. But then we go through some of the more kind of foundational gut healing therapeutics, diet, probiotics, just as a couple examples, and we reevaluate. And once we've gotten through some of those more foundational frontline therapies, if there are still symptoms, likely there's only a smaller cropping of symptoms, that is when a specific targeted trial of HCl can be deployed, and it's easier for the person, the patient, the individual to say, yep, that clearly helped. I was less bloated. I felt less full. I had less belching. Or no, I noticed nothing. Or even worse, I had a exacerbation of reflux or felt heartburn or burning or warmness. And that has seemed to work pretty well for me. I'd be happy to run that test. It was just mostly an accessibility issue.
And also hydrochloric acid supplements are cheap, right? Like $15 a bottle or something like that. So my mentor, who's a little bit old school at the time, he was 77. I don't even know if he's still around, hairy-eyed near. He recommended increasing 1 capsule per meal until you feel a burning sensation. Is that still relevant, the dosing?
I don't think that it is. I don't know that anyone has done a study to robustly answer that question. Mm-hmm. For me, and I should mention that when I wrote Healthy Gut, Healthy You, we did a fairly robust fact check of pretty much every concept that we wrote about, just to make sure we weren't kind of repeating, canards. And it was pretty shocking that there was this circular referencing, but if you followed all the way back, there was a handful of studies from the 60s or 70s, and they really weren't well-performed studies, and they didn't really do a good job of substantiating most of the claims that are made about hydrochloric acid. In fact, some of the books even had the association completely wrong, where hydrochloric acid supplementation should increase this lower esophageal sphincter tone. That was actually the inverse of what some of the data actually had found. So there doesn't seem to be a lot of good data here. And knowing that warming sensation may actually be a byproduct of someone who is having a little bit of gastritis, ostensibly, mm-hmm. I don't think going just below that cusp, it makes a lot of sense, because you could be just below the cusp at which someone is experiencing a little bit of damage. Yeah. But rather to try to find the minimal effective dose, usually between 1 to 4 capsules, tends to be enough to elicit a response. And also looking at it in conjunction with those historical factors, and then doing some of the other foundational work to mitigate symptoms. And all that together seems to work pretty well. There's one other thing I should mention. This is something that was put forth by Richard McCollum when he was on the podcast also. He's looking at a serum gastrin or a blood test for gastrin. And if he sees that above 70 to 75, he's looking at that as an indirect diagnostic for someone who has low stomach acid. And that is something I've been doing in the clinic now for the past 6 months. It's rare actually that you see an elevated gastrin. So I'm still trying to see how well that correlates with these other factors in response to therapy. But that may be something that's a bit simpler, more accessible and cheaper, and available at any LabCorp request. Whereas the Heidelberg, to your point, a bit more expensive and a little bit harder to find a center that offers that.
Interesting. Now, would you expect an elevated gastrin in someone that's been taking a PPI for acid reflux and things like that? Or
yeah, great question. And this is one of the reasons why when I initially looked at gastrin maybe 3 years ago, I didn't start using gastrin, because it is an imperfect marker, and H. pylori infections can skew that. The position in the stomach of where the H. pylori is residing may also skew the gastrin or the stomach acid in different directions, at least according to my understanding. PPI therapy may have an impact. So there was confounding variables that made gastrin imperfect. But after further conversation with McCallum, I realized, well, it may be imperfect, but it may be the best test that we have, even though it is imperfect. So yeah, there's definitely some things there that confound the read, which is why, and this is something I've tried to be consistent regarding across the board, lab marker is only maybe 1/4 of the data that we need to make a clinical decision. We need someone's history, their symptoms, their presentation, their response to therapy, and the lab markers all collectively to make an informed decision.
That's such a great point. You know, we when I was younger, I would look at labs and it was like, oh my gosh, this is elevated. Your ferritin's elevated. We need to get you to donate blood. And it could have been like a transient cold. And so I think we do put a lot of onus in labs, but like you said, you got to look at the history, the context. Sometimes there's laboratory error, whatever. These things are not super perfect. And I think it takes time to recognize that, you know, because of course we get excited when we're young, but you know, for example, I thought I had hemochromatosis one time. I did some manual labs and my ferritin was through the roof and my iron was through the roof. And my mentor was like, just rerun the test. I was like, oh yeah, okay, rerun the test and it was totally fine. So that like stuck with me, and I think it should stick with other people. But going on to, so we talked about hydrochloric acid and supplementation, and I love how you said, you know, sometimes, and I found this too, when you start to dive into literature, something is quoted about whatever from years ago. And then once something credible, you know, an author cites it, then that gets highly referenced. And then it's like the telephone game almost. You can see that in research.
Yep.
Crazy.
Yep. No, it's a fantastic point. And also just to echo your lab testing point, because I feel this is one of maybe a handful of concepts that if we can impart them further into the healthcare consumer, will yield them huge dividends. There is a epidemic of clinicians kind of vacuously treating lab markers and forgetting about everything else. And it's a really serious problem in the field of functional medicine. Clinicians are forgetting how to use all of their other senses, and they're just focusing on treating labs. And the real travesty that underlies that kind of epistemologically is many of those labs are built upon a priori assumptions, and they haven't been fully vetted to actually be accurate. And pretty much every stool test out there has a few markers at least that have not been well vetted. And we had a great podcast with Alana Gurovich, a naturopathic gastroenterologist, who fact-checked some of these labs, and some of the labs couldn't even tell them the methodology of the test they were offering, literally. So it's really important that the healthcare consumer understands that with newness, you know, there's a double edge to that sword. There may be something new and novel to help you, but there also may be a lack of validation of that marker, and it may actually be meaningless. And this has a huge translation to someone's healthcare, because as just one quick example, you will oftentimes see a low diversity score on someone's stool test who has IBS or IBD. The mistake is that thinking that we can treat that lab marker with prebiotics and fiber. Anyone who has followed the IBS and IBD literature knows that while prebiotics and fiber can help those people, there may be a higher likelihood they're going to have a negative reaction and be flared. And that's because the lower diversity is likely a result of inflammation and an aggressive immune system. And so treating the diversity is it's forcing the body to do something that it's trying not to do. So until you can get the inflammation down and the immune system a bit attenuated, you don't want to force feed the flora, because that's part of what the body is reacting against. So that's a good example of how just treating a lab actually takes a clinician, leads them away from the clinical literature that has clearly shown, don't do this in that population, but the lab told me to. And now you do it, and what you're doing is totally antithetical to what so many of the clinical trials have found. The patient flares, and it's just a really kind of, you know, bad situation for everyone to be in.
Oh, that's a great point. I was going to ask you that towards the end as we talk about food, but this is a great place to kind of drill down on what you just said there. So we see that low bacterial diversity is kind of linked with all these different conditions, chronic inflammation, et cetera. What I heard you say there is this sort of inside out control where our own immune system is controlling at some level the populations of the bacteria. Is low, I haven't been following the diversity literature for a while. I used to, but is it still core? Is that something we should still focus on, one? And two, why are Westerners, why do we have such a low diverse microbiome?
Great question. And I should also disclose that I haven't been very meticulously following this literature for a couple of years. And I think we were probably seeing the same thing, which was the research there was so early. I mean, the studies aren't even on the same page yet with methodology. So there's a litany of factors that kind of preclude the ability to get an accurate read. Also, most of those tests are looking at large intestinal diversity. and they're not necessarily looking at what's happening in the small intestine. And so there seems to be this big kind of miss. Part of it is just due to technology limitations. It's much harder to get a read in the small intestine because it's kind of in the middle. You know, the stomach is in the way and the colon is in the way. So it's like this black box. It's hard to access. There does seem to be a trend where diversity correlates with individuals being healthier. But the question is it causal? And this is where I think there's been a really big miss. In those who have more inflammatory conditions, at least as best as I've been able to read, it's not causal, and it's actually secondary to what's going on with the immune system. And there's a few really good points that support this. Those with IBD, inflammatory bowel disease, Crohn's, ulcerative colitis, and those with IBS, they tend to do well and respond well to a low FODMAP diet. Definitely those with inflammatory bowel disease have been shown to respond really well to elemental diets, which are liquid meal replacements that have no fiber and no residue. And we know that those with inflammatory bowel disease or those with IBS oftentimes report being very sensitive to high levels of fruit, vegetable, and fiber intake, especially raw. And this is very antithetical to what you hear, well, you got to eat raw and, kind of the fiber enthusiasts. It's not to say that that's incorrect, but if we picture this spectrum, those who are still more in the acute phase, fiber is like trying to do an explosive squat with an inflamed knee, would maybe be a way of thinking about this. It's one of the hardest things for the gut to process. And so while, yes, we can point to athletes who are doing explosive squats and jumps and say, well, look at that athlete, look at how powerful they are. Shouldn't we all be doing this? Well, it'd be silly to say, well, this person, 3 weeks post-injury should be doing that same thing. And so the hope is that over time, as we work with someone's immune system and their microbiota, they can broaden their diet. But even within these populations, we often see that not everyone does well with a high degree of fruit, vegetable, and fiber intake. Now, it's not to say we have to go all the way to full-blown carnivore, but there is clearly a trend where those foods tend to, the high fiber, high prebiotic foods tend to be ones people have to be a bit more cautious with. So at least as best I've been able to kind of uncode this, it seems like the diversity is really the end result of the immune system. And that's where we should be focusing on, not just trying to kind of artificially raise the diversity, because we know that bacteria feed on prebiotics and fiber, again, because the randomized control trials oftentimes show that those with those immune imbalances will flare from those very foods.
Oh my gosh, what a great point. And I'll just say, just as a small little anecdote, again, I was huge into this research for a while when the Human Microbiome Project came out, and I was a big fan and helped some supplement companies formulate products. And there was so much research on inulin supporting diversity. And so I would give this to practitioners and advise it. And they would call me and be like, Mike, my patient is bloated and gassy. And I said, give them more. It's going to take time. And now I feel so silly for recommending that, but it was really early. But along those lines, and admitting my own silly mistakes, when you saw the popularity of the keto and maybe even carnivore diet, did you start to think like, gosh, no wonder people are looking at this, because you're taking away those fermentable sources, and that's why they're feeling a lot better? Because it seems like from the anecdotes and so forth, we don't have a lot of literature yet or randomized controlled trials, but a lot of people with autoimmunity, with depression, with conditions that are characterized by SIBO and dysbiosis and things like that, tend to really benefit from going on that style diet. So I was curious, what you think there.
Yeah, I mean, it was no surprise to me at all. I always share the story about being on the Paleo FX gut panel maybe about 5 years ago, and feeling like I was a nut because everyone was proclaiming, fiber, prebiotics. And I was kind of like, guys, like, as a clinician and looking at the low FODMAP literature and the IBD dietary literature, there's some huge pools of randomized control trials that you're ignoring. And actually it was a huge gift to me, because I remember going home and saying, like, am I just a complete moron? Or what is accounting for this disparity? And it really led me back to a deeper appreciation of the evidence-based pyramid upon which medicine is built. Observational data is the lowest quality. or actually cell data and animal data is the lowest quality, then observation, then a single control trial, and then a meta-analysis or systematic review. Mm-hmm. And so when I reflected on my opinion, it was different than most, but it was a derivative of higher quality evidence. And that's why I think it ended up being more real world applicable. Kind of to your point, the inulin was based upon the observational data that higher bacterial diversity is correlated to healthier people, but that's just observational corollary. It's another whole few steps up the evidence-based pyramid to say when we give people with low diversity inulin, then they get healthier. And that's what wasn't bore out. In fact, the opposite was shown by low FODMAP trials. So no, I was not surprised at all by that. As a quick counterpoint, there are some people who seem to do better on a higher carb and kind of higher starch diet. And some people who do really well when they go vegan. But I guess as a clinician, it's my responsibility to have a knowledge of all these different diets and then help navigate the person toward the one that's going to be the best for them. And there are some people that we go toward a kind of a lower carb, paleo, low FODMAP, and they feel worse. And so, okay, we got that feedback. It took us 3 weeks. Now we're going to learn and move from that. We're not going to say, well, do it harder, do it more, and kind of force them down that avenue, but rather it's a little bit of exploration to figure out what's going to work well for that individual's gut. But to your point, there's definitely, I would argue, the majority of people do better in that moderate to lower carb intake, especially if they've had various digestive maladies.
That's a great point. I think a recurring theme that people are hearing, it's tacitly implied, is bio-individuality. Because one diet works for someone or the guru who might be ripped and fit and everything like that, it may not work for you. And I think, and I would love to give some diagnostics to kind of help, and maybe we can finish off with the diagnostics to ascertain, kind of where to go next. But one key attribute that I think is under-recognized when it comes to gut ecology health, we talked about hydrochloric acid, but another caustic agent, bile and bile salts. And we know that bile is like not just the soap that saponifies fats. It helps with the microbes. Bile acids are found in the brain and the heart, and their signatures are linked with disease, and there's so much there. So we talked about how with autoimmunity and ulcers and dysbiosis and so forth, we can have reduced stomach acid. But what's going on with all the gallbladder stuff and then sluggish bile?
Great question. And I don't see as much being published about this. It's also possible that I could be missing a pocket of literature here. There are some things that have been mapped out that are, I think, worth noting. One is that small intestinal bacterial overgrowth can interfere with the function of bile. Can deconjugate bile. So one of the reasons why I leave the hydrochloric acid or bile or even enzyme trialing now until a little bit later in kind of the clinical hierarchy, if you will, is because dysbiosis, including SIBO, may cause symptoms that look like issues with bile or with enzymes. And the individual may respond to supplemental bile, but that may be because their bile is being deconjugated by the SIBO. And so even though you're getting a response, it's more so treating a effect rather than treating a cause. There are definitely some people for whom even after they improve SIBO or presumed SIBO, that they'll respond to bile. And there is this, on the other end of the spectrum, kind of this bile acid malabsorption, which can cause bile acid diarrhea. And essentially bile is squirted into the first section of the small intestine, trickles its way down, and then the terminal ileum at the end of the line is supposed to be absorbed back up. But if there is inflammation in the terminal ileum there, or potentially SIBO, that bile doesn't get reabsorbed. And when it gets into the colon, it actually functions as a diuretic. So I don't know if I'm fully answering your question. Some people who do have laboratory indications that they may have sluggish bile, there have been some trials finding that high-dose bile supplementation actually helps to rectify some of those lab marker aberrancies. So there may be something, perhaps we could argue that by deloading the gallbladder's ability to store or the liver's ability to release bile, the glands can kind of focus on repair. This is also seen in the thyroid literature, where thyroid hormone supplementation it suppresses the need for the gland to make hormone, but it also lowers antibodies. And the theory there is because the gland doesn't have to worry about making the hormone, it can focus internally on repair. So maybe the same thing happens with moderate to higher dose bile in those who have lab indications of biliary stasis, but it's not something I see a lot of. So I don't have, I guess, many clinical pearls to share other than those few things there.
Interesting. So it seems that here we go again. We have this allopathic nutrition approach where people say, well, here's bile because you probably have a deficiency or whatever, but the cause could be, again, the bacteria or the inflammation that are causing the deconjugation and so on. So it requires digging and further testing. And again, I want to get into that in a moment, but kind of final question on mechanisms and things like that. Since we're here, we're hearing so much more. We've heard a lot about bacteria over the years, and then the human virome. But then we have all the helminths and the worms. And there's a great book, Epidemic of Absence. Moses Velasquez-Manoff talked about, the dearth or the lack of worms, helminths, is causing our immune system to overreact to things and it's losing its tolerance. Where do worms kind of fit in helminths and helminth therapy? How do you view that? Do you use it clinically? Do you test for that?
Great question. We do test for worms as part of a ova and parasite test. They're not very common. It's quite rare that you'll see a frank worm or amoeba or a real true frank pathogen. It does happen, but it's not very common. And we've had a number of guests on the podcast to discuss the topic of helminths, all the way from William Parker, who I believe is at Duke, through, I'm blanking on her name right now. She's a pediatrician who works with many autistic children. And we've also had some patients who've self-experimented, while they're a patient of ours. We can't tell anyone to experiment, but some patients inform us that they're self-experimenting and we kind of monitor them. I haven't really been impressed with the outcome of helminths. Now, in a pediatric population where Dr. O'Hara, that's her name, is finding, I believe she reports around a 50% response rate. That may be because the microbiota and the immune system tied to the microbiota hasn't fully formed, which by the second to third year of age, that's when the predominance of this forms. Perhaps there's a little bit of latency into, 4-ish, but so that population may be most amenable to some of the benefits from these old friends, as Moises terms it in his book, which I think is fantastic, by the way. In adult populations, in my experience, I haven't been as impressed. There have been a number of studies that have kind of echoed that, where there hasn't been the response that we were hoping to see. That may be a derivative of our understanding right now is too in its nascency, where certain populations may benefit from certain helminths, or they may need to have a combination of certain helminths. Some of the helminths that are being used are not human grade, or they don't colonize humans, so that may be another issue that kind of confounds the read. FMT, Fecal Microbiota Transplant Therapy, is a therapy that has been more encouraging in terms of, as study after study has been published, you're seeing at least a notable positive effect. Not every study shows benefit, and probably the most mixed is in the application of IBS. Pretty good data, in my opinion, for inflammatory bowel disease. And so FMT, I would much rather have someone consult with and do FMT than helminths, because of my clinical experience and then both what's been published in literature, there seems to be a much stronger signal coming from FMT. I think the helminths are interesting, but we may either need to intervene really early for those that work, or we just don't know nearly enough yet to be seeing a consistent, when I say consistent, I mean above 50% notable positive impact. And also with many of the helminth studies, they're self-reported, so the incidence of placebo risk is extremely high.
That's a really good point. So basically, if I heard you correctly, probably a little bit more efficacious in children because their immune system is still getting educated. It's not yet, it's still malleable plastic, if you will. So the worms might be having a better effect, whereas in the adult, you've had years of the tolerance or the cytokine profiles. Fascinating. So with regards to FMT, how do you pick a good donor? Do you use this in your practice with people?
We don't. We refer for people to Mark Davis is part of a association that helps people in the United States find a good donor, go through the appropriate screening protocol, and kind of advises them on self-administration. We've also had on the podcast the people from the Tame Out Clinic to discuss their methodology, and a gastroenterologist. This boy, maybe 4 years ago. I think his name is Nathan O'Connell, who's doing this in Australia. So we've had a few podcast guests on. I would definitely recommend someone who works with someone who is somewhat specialized in that to get the nuances, but it is definitely a therapy, albeit maybe sounds a bit gross, can definitely help people. And I just caught wind of there is an attempt to make the frozen capsules more available for, because this, if there's a good bank and they're producing frozen capsules and those are able to be mailed out, it takes many of the logistical hurdles out of the equation. Finding a donor, testing the donor, self-administration, self-preparation before the administration, the labors of enema. So yeah, I think there's going to be a lot of interesting stuff that happens with and makes FMT more accessible in the coming few years.
That's awesome. That'd be a hard sell. Someone would have to be really motivated. Like, okay, trust me, don't think about this when you're swallowing these capsules. Or would you insert them rectally? They're frozen.
Most people will be taking the capsules orally because they're frozen. Neil Stolman, who's kind of one of the pioneering gastroenterologists in FMT, was on the podcast, and he kind of satirically referred to them as crapsules. Frozen capsules. But yeah, if you can get past that, I would also want to make sure to iterate for people. I look at FMT definitely as a end of the line therapeutic, and it's easy kind of to pay that lip service. We see a lot of patients who've been to 5, 10 doctors at the clinic. That doesn't necessarily mean that you're end of the line. Most of those cases we're able to help. Unfortunately, I think a lot of that is a derivative of the education of functional medicine. As good as it is, has some major holes like we've been talking about with over-reliance on lab testing. And so if you can get into kind of the right clinical paradigm, then what you may think your case being chronic as could be proven to respond very well to the therapies within our toolkit. And I just mentioned that so people don't think, well, I've been to 5 doctors, I got to jump to FMT. It's not necessarily the case. But if you've gone through a clinical model that is very well vetted, then that good clinician will probably make the referral themselves. But also that would be the most opportune time to consider an FMT.
That's awesome. Yeah, it's good to work with someone that like yourself who understands this and so forth. And I guess that kind of leads us to finish up a little bit on testing, because I know there's a lot of labs out there that are looking at stool, looking at small intestinal bacterial overgrowth. I'm sure you have a comprehensive list of resources, but if you can kind of help us kind of in closing, obviously work with the practitioner, maybe reach out to you, but what tests are good, what are not so good?
Yeah. Let me just lead again by saying testing, the consumer should look at testing as the least important thing. Right now, I feel like, unfortunately, the tests are looked at as the most important thing. And, I don't mean to be knocking the field, but it's really pretty disturbing how once or twice a week we'll see a case study where it's just unbelievable how much testing has led them down the absolute wrong path. There's one quick tangent. Sorry to be a little bit verbose here, but we just published a case study. This is one of the other doctors in the clinic. 62-year-old male in generally good health. Only complaint was his quarterly travel to Asia kind of gave him some aches and pains, and he had a hard time with energy, understandably so. It's a long flight. There's a big circadian shift. So he was asked to do $2,300 worth of lab testing by his functional medicine provider, adrenal panel, neurotransmitter panel, amino acid panel, diagnosed with adrenal fatigue, told to go off all coffee and to have lemon water and maple syrup every morning. He took a boatload of supplements. All of this led to no improvement in how he felt. And the poor guy really enjoyed having a morning cup of coffee, and it didn't seem to cause him any ill effect. So we ended up doing, I think, a $300 to $500 blood panel, told him he could enjoy coffee again, gave him some simple tips for shifting the circadian rhythm in preparation for the flight, some antioxidants and other kind of lifestyle interventions to help buffer the impact of the prolonged sitting and the circadian shift stress. And he felt phenomenal. So $2,300 to be told he had a condition which he did not have, to be made afraid of coffee and to see no impact. Whereas on the other side of that, much less blood testing to check for a few things, no diagnosis making him think there's anything wrong with him, no avoidance of the simple pleasure of coffee, and a few targeted interventions based upon common sense that really led him to feel a lot better. So this is why I harp on testing. I know it may sound like a powerful indictment, but testing may do more harm than good at current. I just want people to have that anchor to, moor them as they go out into the world and confront testing. But to your question, I think a SIBO breath test can be helpful. Okay. Again, if we use it as maybe 1/4 of the data required to make a clinical decision, I'd like a lab called Aero Diagnostics. And within the SIBO breath testing, there's a glucose test or a lactulose test. There's debate in terms of which one is the best. You could really make a case for either one. We use glucose. You could use lactulose. One important caveat with the lactulose, because it absorbs past the cutoff from the large intestine to the small intestine, you have to make sure you cut off what you're considering the window of the small intestine, usually about 80 to 100 minutes. Because if the clinician doesn't say, well, this is the cutoff time, and you're looking at the 120th or 140th minute, and you're seeing an elevation, and you call that SIBO, that's not really SIBO. That's more so, yes, there's more bacteria in the colon. More bacteria equals more gas, so we should see the graph go up. So I hope that's not getting too detailed, but there are, a few, notable examples where people are being told that they have SIBO when they don't, because the cutoff time for the lactulose test is not being looked at. So I'd like Aero Diagnostics, glucose or lactulose. If you're more new to these tests, the glucose has a more, I think, user-friendly profile. It doesn't run the same risk of a false positive as the lactulose test does. And then for a stool test, there are two tests that I like. Probably my favorite is the Doctor's Data GI 360, because they will test for pathogens and functional markers, but they will also look at this dysbiosis index, which actually is borrowed from a group in Norway called the GAMAP. And this is the only group that's really had a repeatable measure that will delineate IBS from IBD to a healthy cohort. Many of the microbiota mapping assays are built completely based upon inference, and there's no good normative data, or the normative data is 30 people from the lab who don't have symptoms, and that's what they consider normal. So, okay, it's like the first step, but to pay $300, $400, $500 for this and make all these clinical decisions based upon that sort of validation, probably not justifiable. But the Doctor's Data 360 profile seems to really be borrowing from a good data set. Or also another test called the GI map from Diagnostic Solutions, which is here in the States. It is DNA-based. DNA-based does run the risk for false positives. So even more important than it's looked at as 1/4 of all the data. Also a good test, just requires, I think, a little bit more user knowledge so as not to incorrectly interpret a false positive. And then a good LabCorp panel, looking at some of the basics, CBC, CMP, iron, ferritin, like you mentioned, maybe a gastrin if you're trying to assess what your stomach acid potentially looks like, although, to your point earlier, an imperfect marker. And you can get a real good degree of yardage out of those simple profiles.
I love that. And I love that story that you shared about that client or patient where, they have this gamut of labs, cost a bunch of money. And, it's like, how does that really change the clinical decisions that much? I see that, having worked with doctors for 15, 16 years now. I see that in the younger like new to practice or new to functional medicine. They think that, we got to start out with this whole litany of things. And I think like you said, a good blood panel just to kind of see where you're at, good baseline anyway. But yeah, it's really interesting. A mentor taught me, and of course, when I was younger, I ignored it. But if you do a lab test, and it's if you don't know that it's going to directly change the treatment, then you probably shouldn't do it. And I used to think he's old school. What is it? More the better, but more is not always better. So I love that, and thanks for summarizing those labs, and I think that's super helpful. I guess in closing, I found a few papers that have found loss of immunological tolerance as a risk factor for severe COVID-19. So I was kind of curious to see if you've followed some of that research or what you think, because it seems that many of the people that are susceptible have this kind of smoldering chronic inflammation. We know that could be linked with gut material imbalances. What are your thoughts there as it's related to the viral pandemic?
Great question. I can't say that I've been following the COVID literature close enough to give a great answer on this, although I'm sure you've heard of and you've probably discussed the association to metabolic health and just body composition, also vitamin D and blood sugar. So a lot of the things that I'm sure your audience is very well versed on. Foundationally, there is a body of evidence showing that probiotic supplementation can help with upper respiratory tract infection prevention, and then also shortening the duration. So that I think is important to mention. Now, that's different than COVID-19, SARS-2, but there's probably some overlap between the two, where we know that, again, the largest density of immune cells are in the small intestine. And if there is this link, as you're saying, between kind of the smoldering global inflammation, that may hinder the ability of the immune system to respond adequately. And so the best evidence I've seen from a gut perspective anyway, or as that ties to a simple gut-based intervention, is probiotic supplementation seems to help reduce the incidence and duration of URTIs, upper respiratory tract infections. So that would be the one thing I'd offer people to consider, not in a, oh my God, you got to go out and buy every probiotic and douse yourselves in them. But, a good probiotic, at very least, maybe on and off, seems to be a nice hedge. Now, if all your other lifestyle factors are dialed in and you're eating fermented foods, then perhaps you don't even need a probiotic. For me, checking those boxes, I do find my GI is a bit more resilient to maybe eating out. So not to get too graphic, but I may have noticed before I was on probiotics habitually, eating out, and then the next day I'd have looser stools, or not enough sleep and maybe too much stress, and then I might get food reactive brain fog from a couple of different types of food. And so now I have kind of a morning probiotic routine that I do, and that just seems to keep me still healthy, right? But I don't have that ability to be kind of thrown off optimal quite so easily from some little indulgences. But I would recommend people kind of go through the exercise of try a good probiotic protocol, just as one example, but a good, cheap, safe, one that can be recommended kind of across the board would be probiotics. See if you notice an improvement, and then over time, try to find the minimal effective dose. For me, when I was on nothing, I was okay, but I didn't have those same little perturbations from those, enjoyment points of, off-plan food or alcohol. So I just offer that maybe as, something regarding SARS-CoV, but then also just if you're going to use probiotics to maybe help buffer that, go through the exercise of a trial and then an objective kind of withdrawal to find the minimal effective dose. And that's a good principle that can be applied across the board, because we don't want to expect to need a supplement. So we want to approach the trial objectively and then look at your body's own biofeedback to determine if it's a long-term thing that you want to keep in your protocol.
That's an excellent point. If we could get a little bit controversial and talk about, we talked about the top-down dysbiosis of the mouth, how that can be linked to dysbiosis further down the gastrointestinal tract. We know that face masks are being mandated throughout, presumably the world. I mean, certain countries, for example, Canada is not mandating them. I think the Netherlands, Sweden, things like that. But you have all these people that are kind of re-inhaling their air, and some dentists are talking about face mask mouth and some dysbiosis of the mouth. Do you think there's any side effects from a bacterial standpoint of wearing a mask all the time?
Good question. That's not something I've looked into at all. A couple points I'll offer up kind of in that realm of discussion. One is we should all be attempting to nose breathe as much as possible. I'm sure you've probably discussed this. So if people are mouth breathing, try to kind of monitor yourself and make sure you're nose breathing. And this is actually something for my own endurance capacity I feel like has really helped, is just doing nasal only cardio training. It takes a little while to acclimate, but I do feel like it's increased my performance. So maybe a bit tangential, but and then I did just watch a video today with Dr. Zujin Pneumonia, I think is how you pronounce his name. He goes under the moniker of Z-Dog. And he made a good point, which tied to something I have heard before, which is with vectoring coronavirus, it's not just about being exposed, it's about the duration and the density of the exposure. And that is where it does seem that masks may offer some type of benefit and I suppose mostly from the perspective of if you're going to be in a public place where you can't socially distance for a period of time that's substantial, that's when masking seems to make sense. If you're walking on a nature trail with little to no people around, do you need a mask? In my opinion, probably not. Some of the data that I've seen, I believe there was a rapid review recently that found no effect from masks or only a slight positive impact. That also has to be weighed against what is the way we want to approach this, and are we trying to let this run through the population to develop herd immunity while really trying to protect at-risk populations and kind of find this intermediary where we're slowing the spread, making sure that the spread rate stays underneath the medical capacity, protecting those who are at risk so that hopefully new advancements can be pioneered in how well we deal with this so as to lower the death rate. But I do think there is something to letting this run through the population, because to think that we're going to be able to box it into a corner, I have a hard time thinking that that's highly viable. So I guess I'm kind of in that middle ground where I don't throw out the social distancing or masking recommendations completely. I think there's probably a time and a place for those given the setting. But I certainly don't go to the freak out on the other end of the spectrum, and letting this run through the healthier and especially younger facets of the population to build up herd immunity seems to make sense. Although those who are younger and in contact with at-risk populations, the calculation changes a little bit. So, there's a few things there. I think if we all just think about this logically, we can probably determine a good way to navigate it. Although that being said, I haven't been following this uber closely, so there may be some big holes you could poke in my commentary there.
No, that's awesome. I think that's one of the more rational explanations that I've heard from a long time, and I echo that. I mean, when I'm in close contact, I definitely wear a mask. Not so much that I'm worried about getting super ill, but should I be an asymptomatic carrier? But I do get a little frustrated when I'm on a hiking trail 6 miles in the woods and I see people damn near jump off a cliff with a mask on. It's like, anyway, but
yeah, agreed.
It's a little over the top. Final question here. The excessive hygiene, we're putting Clorox and Lysol. We're washing our hands multiple times. We know that our skin has its own microbiome. What are the consequences of that?
Great question. And I have heard, this is anecdotally, I haven't read papers on this. It's just some of the reports and figures I follow who report on coronavirus, that there are, and I don't know what the metrics being used here, but immunodevelopment of children is likely being compromised due to a lack of exposure to other children and the outdoors and what have you, which that is a travesty, because there is a limited developmental window for that in children. So this is something where, again, caveat, I haven't been following all the details here, but from what I have gathered, children are at an infinitesimally low risk from coronavirus. And so sheltering them with the intention of protecting them is understandable, but we have to always look at what happens on the other side of the ledger. And in this case, you may be doing more harm, because we know that, again, if my assumption here is correct, that the risk from children is infinitesimally low. And I believe the most recent infection fatality rate table from the CDC really supported that. But we do know there's a limited window for them to develop from exposure to dirt, germs, animals. I mean, within reason, the kind of way I frame this and Healthy Gut, Healthy You is old dirt, good, animals, forests, what have you. New dirt, a dumpster, a public toilet, bad, right? So I would, mitigate the unfettered exposure to new dirt. I would let the old dirt exposure kind of run. But yeah, I do think that is an area that we should be careful with children. Adults seem to be a little bit less amenable to those effects of hygiene, although it's probably still a good idea. We do see people in the clinic who overwash, and they say, I have fungus here, and well, where do you use soap the most? Well, I really scrub under here, and we'll have people reduce their soap use, and what do you know? Their crease, groin, armpit, presumable fungal overgrowths go away from that. So yeah, I do think there's a balance to be struck here, and we're probably in a lot of cases going a little bit overboard with hygiene. Although if you are in public and you're touching things and you're coming home and you're in contact with an at-risk population, that makes sense. But I think the point we're both driving at here is, if you're on a trail and when you get home it's Lysol up, that's probably the kind of dirt you want to welcome in. If you're at a coffee shop, a supermarket, I could see the viability of doing that post.
That's a wonderful point. And I love that kind of juxtaposition, so people can kind of conceptualize, the old dirt versus new dirt. And great point. Yeah. And I see that with parents all the time. And, we have backyard chickens, and my daughter often goes and plays with them and doesn't wash her hands. And at first we were nervous, and now she's been doing it 5 years, never once gotten salmonella or anything like that. So I think pets are really good, and let your kids play. I think it's amazing. Dr. Ruscio, I really, really appreciate your time. And I like your objective approach. A lot of us, myself included, we get biased, we get excited, and we want to make a stink out of something. But what I kept hearing from you is like, okay, let's take a step back and look at the hierarchy of data so that we don't rush to making these decisions. So I want to commend you for really kind of exerting willpower and preventing, over exuberance from making conclusions that may not be there. So you have a great podcast, your website. Like, if folks are just listening, where should they connect with you?
Yeah, well, thank you. That's probably the highest compliment I feel like I could be paid, because I do try to just check my own bias. So I really, really appreciate that. And the podcast is Dr. Ruscio Radio. The website is drruscio.com. It's drruscio.com. And they can plug in there for everything from the book to the podcast to the clinic. Definitely, if you don't mind me giving the clinic a plug.
Oh, for sure.
I've just hired some new doctors. There was a fair wait to be seen by me when it was just me in the practice. But now I've been kind of building out the clinical team. And the reason why I showcase that is it's just really disheartening seeing, like the case that I just shared with you, that stuff happened. Because that's an example of someone who spent money and 6 months living in fear and like a lifestyle fettered fashion. And I'm just really trying to prevent people from traversing down that path. It's not to say all functional medicine is bad. I don't want to represent it as such, but I can't ignore just the wealth of case studies that come in that I'm really concerned about the way things are handled. So if someone is in need, we do offer telehealth. And I'd be more than happy to kind of help people navigate a more responsible line of being progressive and open-minded, but we're not going to, just jump on the newest thing just because, and we're going to really make sure we interrogate any new test, any new treatment to make sure that what we bring to the individual is really something that, we would do ourselves or for our family or for our friends.
Super important. I mean, and you're, first of all, saving money that way, and then not going down a rabbit hole that may not exist because one test is a little out of line. So I commend you for that. And I'll put all those links in the show notes. And your book is selling really well. There's a bunch of 311 reviews I saw before we started. So it's selling really well. That's great. Any plans for a new book in the future?
At some point, I want to touch up the Healthy Gut, Healthy You, just to add a few things, although everything in there is still pretty darn cutting edge because, like we talked about, all the recommendations are built upon the highest level of evidence. And so there's all, these new academic findings, but those are more so in that lower layer of evidence. The next book will definitely be on thyroid. It's just like we were talking about, we're supposed to talk about gut, and we kind of opened up probably because I steer us there, but toward thyroid. But there's just so many people who are being given incorrect information about thyroid. And so that will definitely be, I think, the next book that I write, because there is something there, like we talked about, but boy, there's so many cart before the horse cases. So that would definitely be the next book.
Right. Thyroid and sleep.
No plans just yet, but
That's awesome. But keep up the great work, and thanks for coming on.
Yeah, Mike, thanks so much. It's been a pleasure.